Hi everybody, today we'll be discussing about Mesenteric Ischemia Part 3. In this we'll be discussing individual causes of Mesenteric Ischemia, acute Mesenteric Ischemia. First one, Arterial Occlusion, acute Mesenteric Ischemia. In this, one of the most important causes emboli. Emboli leading to occlusion of the arteries. The other cause is thrombi. Other is arterial dissection and vasculitis. First coming to emboli. These emboli, from where they come? They come from the heart or aorta. From there they lodge in the SMA distal to the origin of the middle colic artery. Okay. Then, so how it appears on the imaging? It appears as a central filling defect in the arterial lumen. This is the vessel, this is the emboli. They appear as central filling defect. So other imaging findings are there will be abrupt termination. When we do a CT angiography, there will be abrupt termination of the vessel. This is called as cutoff sign. One more sign is central filling defect or eccentric luminal ring sign. So emboli in the other visceral organs, for example spleen and kidney. Because of the sudden nature and lack of collateral vessels, as it is an acute cause, suddenly it appears, suddenly the emboli has appeared from the heart and blocked the vessel. Due to sudden nature, there will not be any collaterals, and patient presents with severe pain, and that is worse than with the arterial thrombosis. Then coming to thrombosis causes. So there will be background atherosclerosis. So it occurs near the ostium when of the bowel is affected. So here there will be already a background history of atherosclerosis. From there we get the thrombi. It causes occlusion near the ostium. Here the long segment of the bowel is affected. In emboli, it's like the emboli they get lodged distal to the origin of the middle colic artery. Here normally how the patient presents. There will be a patient with a history of vasculopathy. They present with new pain or persistent abnormal pain. Suspicious for acute mesenteric ischemia. So do a CT angiography, look for arterial occlusion and bowel findings. Collaterals will be present. So in this arterial occlusive disease, what are the bowel findings? Normally bowel will be thin walled without any mural edema or hemorrhage, and bowel wall enhancement will be decreased. Paper thin bowel wall with decreased enhancement. This is normal the feature. Exception is when there is arterial reperfusion. In that case there will be the target appearance. The bowel findings corresponds to the distribution of the occluded artery. This is one of the important features. Veno-occlusive acute mesenteric ischemia. Generally it occurs in younger patients. So they'll have a history of hypercoagulability due to systemic or inflammatory conditions, history of portal hypertension, recent surgery. In these people they may get veno-occlusive AMI, or due to a tumor which causes extrinsic compression. This also causes chronic venous congestion. So what will be there? There will be luminal filling defects with a thin peripherally enhancing rim corresponding to the venous wall. Just go along the veins, there will be luminal filling defects with a thin peripherally enhancing rim corresponding to the venous wall. Tributaries to the occluded vein are enlarged, and synchronous splenic and portal vein thrombosis may be present. Okay, so what are the imaging findings? When you see the bowel wall, there will be target or halo pattern, markedly thickened with a target or halo pattern of enhancement. So mucosa will be enhanced, submucosal edema will be there, outer serous or outer muscularis propria will be enhanced, giving a target or halo pattern. There will be mesenteric fat standing and fluid. Coming to non-occlusive mesenteric ischemia. So in whom we get non-occlusive mesenteric ischemia? Systemic hypotension, for example heart failure patient, cardiogenic shock, long-term hemodialysis, hypovolemia, septic shock, trauma, hemorrhagic shock, aortic insufficiency, recent heart surgery. And also patients who is having vasoactive cardiotonic drugs, distalis, phenylephrine, amphetamine, vasopressin, cocaine. So what happens in this condition? There will be mesenteric vasospasm. This lead to non-occlusive mesenteric ischemia. So what are CTE features? There will be narrowing of the mesenteric arteries, the first order branches. There will be reduced caliber of the superior mesenteric artery. The affected bowel normally will be like watershed areas between the vascular territories such as splenic flexure, sigmoid colon. Okay, there will be narrowing of the vessel, that is very important. Reduced caliber of the SMA. There will be influx in the spleen, liver, kidneys. CT hypoperfusion complex, what is that? There will be small caliber aorta, collapsed IVC, hyper enhancement of the adrenal glands and kidney. This is very important. What will be there in CT hypoperfusion complex? There will be small caliber aorta, collapsed IVC, there will be enhancement of the adrenal glands and kidneys, hyper enhancement. So normally if you correct this condition, mesenteric perfusion will be improved. Coming to Strangulating bowel obstruction. This is here there will be like ischemia, infarction of the obstructed loop. Most common in closed loop obstruction. What is it? There will be segment of bowel is obstructed both proximally and distally at the single point. So what were the findings? Obviously there will be reduced bowel wall enhancement and mesenteric fluid. Coming to chronic mesenteric ischemia, it's also called as intestinal angina. Chronic stenosis or occlusion of one or more vessels, mainly celiac axis, SMA or IMA. Secondary to atherosclerosis. Less common causes: Burger disease, Takayasu arthritis, fibromuscular dysplasia, post-surgical intimal hyperplasia. Normally patient will be 6th decade of life and smokers. In these conditions, and mainly most important cause is atherosclerosis. There will be history of peripheral vascular disease or coronary artery disease. So what are the findings in chronic mesenteric ischemia? There will be stenotic or occlusive mesenteric arterial blocks, prominent collateral vessels. So why you do CT angiography? To especially pre-procedural treatment planning, to look for any collateral stenotic, where is the stenosis, accurate grading of the mesenteric arterial stenosis, assessment of the prior stent or surgical graft patency. For this we will do an angiography. So this is regarding chronic mesenteric ischemia. Thank you.